this is just a good breakdown. It's always good to see what the previous exams have been like, and obviously cardio is going to be a big topic, so 9 marks. Obviously neuro as well was a big topic last year. Don't know why. I don't think it should be that much. And here's just a list of like past OSCEs, and they always examine key things, so just know your key presenting complaints really well. And this was also the year before, so you can see like cardio, murmur examination, risk assessment, basic life support, diabetes, asthma, migraine, like all very, very common stuff. So don't be too stressed about them and you'll all be fine. So today we'll be going through cardio, obviously, and I'll just be going through pretty much the key matrix conditions. We'll be speeding through some things a bit quicker than others, but if you want me to slow down or want me to go quicker or answer any questions, just message me. Feel free to message me privately as well if you don't want to message into the group. Always happy to have questions, and if you need any help, just like message me after the session. Yes, and then we'll do some ECGs and EMQs throughout. This is also the link to our VESPADS group. If you haven't been, we have pretty much lectures on every topic, almost, and lots of like resources for PATH as well. I heard that you guys are stressed for PATH from somewhere, but honestly, don't be. They're always fine. So these are just the conditions we'll be going through today, and we will start off with atherosclerosis. So I mainly just had a point on this. You know, it's not going to be an OSCE station, but knowing these risk factors really, really well is really important, because as I showed in that past OSCE STEM history, they really like going through like your cardiovascular risk management. So these are all things that they would want you to talk about. So smoking, diabetes risk, hypertension, lipids, family history, lifestyle, all of that stuff. Very, very, very important to mention, especially if it's a cardio station. I would just mention it anyway, but always need to mention all of these things. Complications, we know we'll be going through these: ischemic heart disease, stroke, PVD, etc. And just again, always mentioning your SNAP-W in your lifestyle management, because this will address all of your risk factors that we're worried about. And always making sure that they're on the right medications for certain things. And always in management, I think for pretty much everything as well, it's always good to talk about a medication review, especially in the elderly patient, because that's when you get things like triple whammies, and they love to test that. So always look at what medications people are on. So ischemic heart disease, probably the biggest topic that you'll have to know about that will come up undoubtedly. So split into stable angina, which is much more predictable, and then our acute coronary syndromes, which are, as the name suggests, acute. And we've got unstable angina, and we've got acute myocardial infarctions, which are then split into NSTEMIs and STEMIs. So it's a spectrum, as pretty much I just said. So starting off with like stable angina, then unstable, NSTEMI, STEMI. It's pretty much just a progression of occlusion of your arteries. Again, risk factors, need to mention them. Probably something I would write on a bit of paper as well for the OSCEs, or I don't know if you actually can write on paper, but don't forget them. Obviously, atherosclerosis is our underlying risk factor, but who cares? And there's some other less likely causes, but you know, they're not going to test that. Obviously, again, our typical history is going to be a crushing retrosternal chest pain, radiation to the jaw, between the scapula, but always need to think about the people who present a little bit weirdly or differently. So that can be women, older people, patients that are diabetic. Lots of different patients can present weirdly. I once heard of a story of a man in Warrigal who presented with testicular pain. So I think that's a good enough reason to do an ECG in pretty much everyone that gets into ED. And again, asking your autonomic symptoms, so nausea, vomiting, diaphoresis, palpitations, syncope. If you don't have these things, if they're not short of breath, they're not sweaty, they don't have any nausea or vomiting, no palpitations, nothing at all, it's a little bit more unlikely to be an AMI. I have seen a question before of the typical story of like a crushing chest pain, that radiated to like the interscapular region, but they didn't have any of these things. And it was a dissection, and a lot of people thought it was ACS. So just keep an eye out for that. Examination. So starting off, are they well or are they unwell? They're going to be unwell. Their color, what do they look like? How's their breathing, all their vitals, and you're going to do like a chest exam. So investigations, ECG, troponin, and the cath lab, or getting an angiogram, are the three things that you absolutely need to mention. If you forgot any of the other things, that would be forgivable. But if you forgot an ECG, troponin, or to mention that you would like to get them to the cath lab, that would not be as forgivable. So don't forget those things. And then our acute management, again, they like to test this a lot. So our Monash T, I like to add the T on the end. It's just a little extra thing to make you look a bit smarter. So morphine, oxygen if it's low, nitrates, aspirin, and save the tissue, probably the most important one. So this is where we want to get them to the cath lab, and it's within about 90 minutes. So they'll also often test whether it's like in a rural hospital or, you know, one of your big tertiary centers. So if you are in a rural setting, probably not likely that you're going to be able to get them to a cath lab within 90 minutes. So you're going to want to thrombolize them, and then obviously send them off to the appropriate center where they'll have it anyway. And then heparin and telemetry. So you're going to put these people on telemetry. And can anyone think of a reason why we would be wanting to continuously monitor these patients? Why would we want to monitor them continuously? You can pop it in the chat. Yes, so arrhythmias, and a few people are messaging privately. Yes, so some people are saying AF, some people are saying VF. So ventricular fibrillation or tachycardia and then fibrillation is one of your main things that we're worried about, and it's one of the main reasons why people die in like the acute setting after they have an AMI. And then chronic management, not often tested, or sorry if that keeps going. So SNAP-W again, and then statins are good. They're shown to be protective. They kind of help protect that plaque. Aspirin and clopidogrel. So you want to be putting these people on dual antiplatelet therapy, not just aspirin. An ACE inhibitor, beta blocker, and a GTN, which is PRN. And just think about, I haven't really got a separate thing on stable angina because it's pretty much the same. It's just your kind of more predictable event. But you can also think about calcium channel blockers for stable angina. So in terms of the complications, as I mentioned before, arrhythmias is your big one. So you know, VT going into VF, torsades, asystole, and death. Cardiogenic shock, so the heart just can't pump anymore and you'll go into APO, you get lots of fluid on your lung. Cardiac tamponade is another big one in the kind of 1 to 14 day region. So you will just get a ventricular wall rupture. And then later on, weeks to months, you get aneurysms because the wall is just really weak and shitty and it starts to bulge out. And that can be bad. And CCF is probably the biggest thing. So ischemic heart disease is one of your biggest risk factors or biggest causes of developing CCF. So here's just a little table again, going through all the changes that we'd expect. So ECGs, definitely important to know. So stable angina and unstable angina usually don't have changes, but unstable angina can. So just if they do have ECG changes, don't 100% rule out unstable angina in your mind, but they usually don't. So these are just the ones that they sometimes can have. An NSTEMI, you can have ST depression, but again, sometimes you don't actually get anything either. But a STEMI, absolutely, if you have ECG changes, most likely to be a STEMI. And just know when your troponins are positive, so with your STEMIs, both types, you'll have troponin rises. With your 2 types of angina, you don't. So who can tell me what this ECG is? You can also turn your microphones off and just shout out the answer if you want. Don't mind. few different answers. Yes. Good. So a lot of people are saying pericarditis, some people are saying STEMI. So it's good that I like that some people are thinking of pericarditis, because I often do the same thing. But yes, this one's an inferior STEMI. So 2, 3, and AVF have clear ST elevation, and they're your contiguous leads. And then you have reciprocal depression kind of in your anterior leads as well. So a typical picture of an inferior STEMI. How about this one? Go with your gut as well. Don't think too much into it. I'm getting lots of different answers for this one. Ah, yes, someone finally got it right. So this one is actually just sinus rhythm, normal ECG. I know it's tempting to think like, STEMIs and things like that, but there's a P before every QRS complex. The T waves. Some people are saying, are they peaked? Not really. I often think that the T waves are peaked, and I'm always drawn to hyperkalemia. But when you see an actual peaked T wave, look, I don't actually think I have one in here, which is shit of me, but look up what like a peaked T wave looks like, and they are really peaked. So if you're in doubt, it's probably not. And the ST depression or elevation, it has to be, quite a bit above. I don't actually know the full thing. Oh, Maddie's here. Hello, Maddie. Like 2 boxes or 2 small boxes. So it has to be, quite a bit above or below the RSO electric line. And just another question as well to consolidate. Yes, Chelsea. Yes, Jackie, Lauren. Yes, you're all doing good. All correct. Very good. So this one is acute coronary syndrome. I'm glad this didn't trick any of you. So because we don't know what the troponins are, we can't definitively say what this is. And just our best thing is just to say acute coronary syndrome. And just one more before we move on to the next topics. Yes, you are all getting it right. Very good. Inferior AMI, definitely know your leads, because this is a way that they often present their questions, and saying that leads 2 and 3 had this, or V1 to 4 had so and so. So good, know your leads. This is an inferior AMI. So moving on to myocardial and pericardial disease, fun topic. So CCF, probably the other biggest topic that there is. So heart failure on both sides, so right and left side. And our different types is preserved, mixed, and reduced ejection fraction. So if it's preserved, it's above 50%, our ejection fraction above 50%, and our reduced is below 40%. Mixed, don't even worry about it. And when we think of the patients that we see in hospital, they're pretty much going to be all of our HEF-REF people, so reduced ejection fraction. If your ejection fraction is over 50%, that's pretty good. You're going to be able to move and do a fair bit of exercise before you're becoming short of breath. So the main people that we're concerned with are our HEF-REF people. Amazing. So risk factors, again, same things as before. I'm going to say it over and over again. Always need to kind of touch on these things in your history. In terms of etiology, as we just went through, ischemic heart disease is like your big one for HFrEF specifically. If you just think that you've got this ischemic heart disease, you've had a bit of the tissue die, that tissue is not going to be able to pump as effectively anymore. You're going to get a reduced ejection fraction. And another big one that I guess sometimes comes up in questions is an alcoholic dilated cardiomyopathy. Very common question to come up, I think, that often leads to a HFrEF. And then in terms of HFpEF, hypertension, diabetes, aging, HOCUM is, uncommon, but again, comes up. And like your restrictive cardiomyopathies and infiltrative disease, like your amyloidosis, sarcoidosis, that pretty much kind of like constrict it and make it a bit harder for the heart to pump. So in terms of our pathophysiology, been through this, and I'm sure you all know it, but you get kind of SNS activation, which is not what we want. We get RAS activation, also not what we want. But the one good thing that the heart, well, that the body does, is increase BNP. So this is trying to prevent remodeling, and it acts as a diuretic to try and get rid of the extra fluid that the body has. So in terms of our history and examination, you can just think of it as like left-sided and right-sided symptoms and signs. So our left-sided things, so it's going to be kind of moving back into the lungs, and that's going to be our dyspnea, orthopnea, P&D. Absolutely ask those questions in a little trio. They all come together. Also a cough and like any sputum. So for APO, the typical thing that they get is a pink frothy sputum. In terms of right-sided, so it's going back into the body. So you're going to get edema, so in the ankles, the sacrum, abdomen, kind of quite a big tummy. So all things to ask about. And then generally they'll be very fatigued. They might be dizzy. They might have anorexia. So they're your key questions that you'll ask. In terms of examination, so left side, they might have cold peripheries because they're not getting enough blood flow. Bibasal crackles, absolutely. Hypotension, displaced apex beat, so they're cardiomegaly. And then right-sided, your JVP, ankle edema, ascites, pulsatile liver, all very, very common. But I can't see them doing any real examinations this year. Again, you don't need to know this very specifically, but just know that there's different classes of heart failure, so 1 to 4, and it's pretty much just an increasing severity of your physical limitation. So 1, pretty much no limitation. 4, you can't even walk around without getting completely short of breath and feeling like shit. And then in between. So investigations, you can do a lot of things here, but the key ones to do, I guess, ECG for everything. And you will do pretty much like your full thing of blood. So FBE, USC, LFTs, blah, 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 blah. But BNP is one that's specific for heart failure. So definitely mention this. And in terms of imaging, absolutely a chest x-ray, because if we're worried about things like APO, but we can see all those typical signs, which we'll go through, and an echo. So either transesophageal or transthoracic, but your toe is always best. And chest x-ray signs, I should have had this blacked out too quizzy, but I don't. But it's going to be our A, B, C, D, E, mainly for APO. So alveolar edema, which is our bat wings, and it's pretty much just the kind of perihilar effusion bilaterally that you see. So this one doesn't have the best bat wings, but I've got another picture that will show it. Curly B lines, they kind of just say them, you're not going to see them, but they're the little lines, the horizontal lines at the peripheries of both lungs that you'll see. Cardiomegaly, absolutely. Diversion of upper lobes, and effusion. So again, these here aren't too bad, but you can just see flattening of your both your hemidiaphragm. So yes, this is a bit of a better photo and a bit of a better photo to show the bat winging, definitely. You can clearly see that there is some cardiomegaly and there's definite blunting of at least the right costophrenic angle. So an effusion. Yes, amazing. So management, again, comes up all the time. You need to know it. Our acute is going to be our LMNOP, but just remembering to do it in the reverse order. So obviously always starting with doctor's ABCD, getting senior help, blah, 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 all of that stuff. So, and then starting off with posture, so getting them upright. You want to give them oxygen. So this can be through CPAP or BiPAP. Say BiPAP to the fluid. That is how I remembered it. I also saw this in the hospital one time where a man didn't get this and that man died, which was a shocking turn of events. And now I hope you all never forget to give people with APO oxygen. Nitrates, you need to for vasodilation. Morphine and Lasix or furosemide, get rid of that fluid. In terms of chronic management, so lifestyle, SNAP-W, never forget. But the biggest thing that I hope some of you have seen in hospital is their daily ways and fluid and salt restriction. Absolutely need to do them. They're the two most important things that you can do because it's actually ridiculous how much their weight changes, especially once they go on furosemide and they're on a very strict fluid and salt restriction. In terms of medical, so ABS, is our key 3 drugs that are proven to work for CCF and have proven mortality benefit. So an ACE inhibitor, beta blocker, and spironolactone, never forget. And then also just like to add another step is FND, so furosemide, nitrates, and digoxin are all kind of things that you can go to next in terms of your chronic management. And then our complications, there's a lot of complications. You can have acute decompensation. So again, these are usually the people that will be in hospital. So if there's any sort of ischemic event, if they've got an infection, anemia, arrhythmia, that can all further decrease your already shitty ejection fraction. And they'll just be very sick. And yes, we know all these. And then cardiomyopathies, won't spend too long on these at all. But there's just a few key ones you need to know, HOCUM being one of them, often just like one EMQ. And then our dilated and restrictive cardiomyopathies. And this is just a good picture showing HOCUM, how it's really this main like septal bit here. And you can see how it's just completely going to block your aorta here. And so it's typically that young person that will just like drop to the ground when they're playing sport or something. So not good. Yeah, so HOCUM, as I said, young person sudden cardiac arrest or death. They've got a very jerky pulse and you can just give them an implantable cardioverter. Dilated cardiomyopathy, alcohol is your big thing. Don't forget alcohol. And you pretty much have the same symptoms and signs of CCF. And management is also quite similar. So ACE inhibitor, vasodilators, digoxin, and anticoagulants. But for pretty much all of these, a transplant is what you hope to get to, but not really feasible for everyone. And then our restrictive ones, so things that our infiltrative things are going to be the main ones. So hemochromatosis is always a good one to think about. Cancer, uncommon, and idiopathic. And so it's just going to be a very rigid heart. And again, same symptoms and signs of CCF, similar management, transplant if you can, but not really available. Don't worry too much about cardiomyopathies. No one really cares about them. So myocarditis, again, not too much of an important one to know about, but we'll run through the key things. So obviously it's going to be an inflammation of your myocardium, and it's going to be mainly a viral cause. So like the question is usually going to be a younger person who's had like an urti or a cough and a fever or something, and then now they've got kind of chest pain or palpitations. So yep, infection, usually urti, and palpitations is usually going to be the key symptom that they'll have, mainly if you think it's in the muscle of the heart and it's all kind of inflamed, you're going to get palpitations of your heart. alongside a few other symptoms. So investigations, ECG for everyone, but the main two that is a bit more specific for this is your CK and your troponin, because these are two, well, I guess myocarditis and pericarditis are sometimes both things that can cause a troponin rise, and obviously you're going to be thinking, oh, they're having an AMI, but probably not. And then you can also do like your ESR, ANA, rheumatoid factor, if you're thinking like a systemic disease thing like lupus, and do your viral serology, and then all of your imaging, definitely. It's a very kind of benign condition. It's self-resolving, supportive care. I mean, they're only going to be in hospital if they're really, really bad or short of breath, but otherwise they'll just be at home, and it's not that bad. Pericarditis, so inflammation of your pericardium now, and again, very similar etiology, so like your viral things, Coxsackie, measles, mumps, rubella, but also a post-AMI is also another good one to think of. So you can get an early pericarditis, but the main one that I'm sure all of you are aware of is your Dressler's syndrome, which happens like one of your latest complications that can happen. And the very typical, very buzzwordy history is going to be an acute onset pleuritic chest pain relieved by sitting forward and worse when they're lying down. So keep an eye out for that. Fever, rigors, night sweats. And like I said before with CCF, how you would ask, dyspnea, orthopnea, P&D, all in one. If you're asking fever, just ask rigors and night sweats as well. It's one thing that you should ask as a little trio. If you say one, say the others. And lethargy. So investigations, ECG, definitely, as some of you were already aware of, like pericarditis is a big one that they often like to test. I think it was in our exam last year. So just know widespread ST elevation. Similar bloods and imaging to what we did before, CK, troponin, CRP, ESR, all of that. Some people asking, would the cardiac enzymes be elevated? It can depend. I did look this up as well because I thought, it's not really in the muscle of the heart, but I did see sometimes it can be raised, sometimes it might not be. It definitely will be with your myocarditis, but not 100% sure, and I don't think it's something that's going to be very specific either, so sorry about that. Management, restrict activity, rest, fluids, etc. And then first line is going to be your NSAIDs, and it's usually indomethacin that is mentioned as like the key one that you'll use, and colchicine can also be used. Can move on to steroids if your NSAIDs aren't working, and treat the cause. So same for the previous one. If it is, for whatever reason, bacterial, give them antibiotics. Very good. So cardiac tamponade, one of our red flags. So we've now got fluid in the pericardial sac, and the biggest risk factor is going to be our trauma or post-surgical patients, which is obviously going to lead to a rupture. So if there's like any weakening in that wall, pericarditis can also cause it, but far less likely, and any kind of connective tissue disease, malignancy, good to think of. Chest pain, so is going to be our main symptom, but relief by sitting forward as well. Lightheaded, palpitations, shortness of breath, so a little bit non-specific. But on examination, however, Beck's triad is our key thing to know. So low blood pressure, they'll be hypertensive, muffled heart sounds, and a raised JVP. So definitely know that trio, it comes up quite often. And then we can also know these phenomenon, so pulsus paradoxus and pulsus and electrical alternans. So on investigation, ECG, this is going to show us our electrical alternans. So where we get the QRS complexes going like big, then small, big, small, big, small. But overall, because there's still fluid around the heart and it's not going to be able to kind of beat as strong as it would like to, they're all going to be relatively low compared to like your normal QRS complexes. FBE, TROPS, CRP, definitely, and then imaging on a chest X-ray, you can see the water bottle sign. I don't have a, that's not it. I don't have a chest X-ray of it, but it's just like a really big fat heart and like a narrow top. So it's a water bottle. In terms of management, so again, doctors A, B, C, D, and senior help, never forget. And pericardiocentesis, so draining the fluid, is just going to be the main thing to do, not really much else. And here's just the specific space. So 5th intercostal, left sternal border, and 16 gauge needle. Now, who can tell me what this is? And it's not cardiac tamponade. Yes. Very good, everyone. So this is APO. Definitely want to like nail this chest X-ray type of picture into your mind. It can look a bit differently, as like you've already seen from the 2 X-rays previously. It does look a bit different, but you can clearly see like the perihilar effusions bilaterally, which is your bat wings, big heart. There's clear pleural effusions bilaterally. Yes, APO every day of the week. How about this question? Yes. Very good, everyone. So this is H. Again, a question that comes up a ridiculous amount of times. So it's just a lot of words for saying that this woman has heart failure, and these are all the medications she's on. And we're thinking about her ABS. She's got an ACE inhibitor. She's on a beta blocker, but there is no spironolactone in sight. So we need to put her on spironolactone. And 2 more. Yes. Very good. Most of you are sending answers. So let's go through the first one. So 79 is E, as pretty much all of you have said. So yes, 20-year-old male, severe palps, collapses with syncope. He's got left ventricular hypertrophy, severe stenosis beneath the aortic valve. That is your HOCUM every day of the week. Very good that you all got that. And then 80 is G, as pretty much, again, all of you said. Very good. Like this didn't trick you. So 24-year-old male with upper respiratory tract infection with palpitations and dyspnea. And he's got clinical signs of heart failure, and he's just got conservative management. So this is your very typical myocarditis picture with that palpitations and dyspnea. There's no real signs of like chest pain or anything like that. So, which would lean you more towards a pericarditis. And they've done conservative management as well. He'd definitely be on something if he had pericarditis. 2 more actually. Yes, and all of you. Yes, and I love when some of you put in extra information. You're far more clever than I was at this stage. But yes, 62, as all of you have said, is definitely B. So voltage is reduced in all your leads. There's a lot of fluid around the heart, so like your ECG is not going to be able to pick it up as easily. And then again, as pretty much all of you said, this one's an anterior myocardial infarction. Very good. So moving on to valvular heart disease now. So this was a little slide by Maddie when we did ECGs and murmurs many, many moons ago in Vespuds. And there's just a few little key rules, I guess, that she made up for, not that she made up, but she kind of thought of for murmurs, which are just good to think of if you are kind of still struggling a bit with them, but I'll leave that with you. And this is something also that I used to do because murmurs just kind of, I would learn them and I'd be like, yep, great, I know them. And then they would just leave my head. So I would always draw out pictures like this, knowing like your systolic and your diastolic ones, and just knowing the key murmurs under each one. But I think the main thing that helped me when I was struggling with it was, I guess, I just knew that aortic stenosis is like your key systolic one. And so if you just know that aortic and pulmonary go together with everything, so aortic and pulmonary stenosis will be systolic, and then mitral and tricuspid, they're just the opposite one. So mitral and tricuspid regurg will also be your systolic, and then it's just the opposite for diastolic. And that is how I just remembered which ones they were. I mean, and even if you know just that, you'll still probably be able to pick the question. So this is the key ones that we'll talk through, and definitely gonna like kind of skip pulmonary stenosis, regurg, tricuspid stenosis. They never come up and no one really cares about them, but we'll go through the other ones, and we'll go through the investigations as well. So aortic stenosis, one that will definitely come up in some way for you, is your typical crescendo, decrescendo. So you can see down here, it goes up and then down. Very, very easy to hear. And it's an injection mid-systolic murmur, and it radiates to your carotids. And if it doesn't radiate to your carotids, but it's, you know, everything else is still the same, then that's going to be your aortic sclerosis. And also knowing that it's louder on expiration. So if you think of where the aortic, well, the way I think about it is your aortic, pulmonary, tricuspid, and mitral. The ones that are in kind of the straight line, so your pulmonary and your tricuspid, they just form an I. So that's going to be the ones that are louder on inspiration. And then your aortic and pulmonary, aortic and mitral, sorry, are they going to be the two that are louder on expiration. I need simple things for explanations to much more complex things. So in terms of the cause, it's usually just age, but they can also have a bicuspid valve, which is like a congenital thing. Key symptoms, SAD, syncope, angina, dyspnea. Very, very typical of aortic stenosis. And their key signs that they'll show up is narrow pulse pressure. So if you think you've got this really kind of stenosed, thickened, crusty old valve that doesn't really like open and shut very nicely, it's just going to be, the blood's going to be flowing through it at a pretty steady rate, not going to be like a big flow of blood and then reduced. It's just going to be very slow to rise. So narrow pulse pressure, and it's very slow rising and steady. And you can definitely feel that when you like feel their radial pulse. Other key ones, they're all pretty non-specific to be honest, but the split S2 sometimes comes up, an aortic thrill, and I guess that there's no displaced apex. So with your stenotic murmurs, they don't usually lead to a displaced apex, but with your regurgitant murmurs, they usually do. So that usually comes important with like mitral stenosis versus regurg, whereas we'll get to it. So mitral regurgitation as our other key one. So these are going to be pansystolic murmurs at the apex and with radiation to the left axilla, and it's louder in the left lateral position and expiration. So something that you would do in an examination, but probably not anytime soon. Key causes is going to be an AMI. So if you have the muscle rupture, the valve's just going to go to shit and it's not going to be able to pull properly anymore. Symptoms, so it's going to be like your left heart failure type thing. So dyspnea, orthopnea, PND. So in terms of the signs for these ones, you are going to get a jerky pulse, and a mitral valve prolapse often has this mid-systolic click. So that's come up in quite a few EMQs before. So knowing this mid-systolic click is associated with mitral regurg. And yes, rheumatic heart disease can do this too. Rheumatic heart disease can do any of them. But in terms of Monash land, mitral stenosis is the one to know for rheumatic heart disease. Yes, so pansystolic murmur, it's going to be at your left side, it's going to radiate to your axilla, and you can have a displaced apex beat as well. So quite an easy one to pick. And then tricuspid regurg is going to be pretty much the same sounding thing, just at the left lower sternal border, so your tricuspid position, but louder with inspiration, not expiration. And the main thing to think of for tricuspid regurg is going to be your IV drug users, so leading to like a infective endocarditis, but can also be any sort of pulmonary disease that leads to right ventricular dysfunction. Pulsatile liver is sometimes something that they like to talk about. So if you're getting just a lot of blood flowing back into the right side, it's kind of like your right-sided heart failure type picture. So a pulsatile liver is a thing to keep out for. And yes, pansystolic murmur. And the other less common one is HOCUM. So pretty much the same sound to aortic stenosis in that it's ejection systolic, and it's kind of just inferior to the aortic region, because if you think it's mainly like an issue that's just below that aortic valve, and it's louder on Valsalva. That's the biggest thing for HOCUM that they will mention. And so this is another great drawing by Maddie. So just showing what it looks like on Valsalva. It's just a lot bigger. So don't forget to mention, I guess, if they were to ask you questions on examinations, they would like you to mention like your dynamic maneuver. So getting them to roll over to their left lateral, doing inspiration, expiration, and your Valsalva, or bearing down. And we went through that before. So aortic regurg, moving on to our diastolic murmurs now. So this is going to be our decrescendo, so early diastolic decrescendo murmur. So right at the start of like your S2, and it goes down, decrescendo. And it's going to be over our pulmonary area, that's louder on expiration and also squatting. Quite a few different causes for these ones. Don't need to really know them in any specific detail. But I guess infective endocarditis, again, can affect any valve, and things like dissection are big ones as well. So symptoms are acutely going to get like your dyspnea, APO, fever, or chest pain, if that's like if your IE is your cause. But otherwise, if it's chronic, you can just have like your similar to aortic stenosis, I guess, in like your SAD, syncope, angina, dyspnea, palps. It can also be asymptomatic. Sorry if people can hear that. So in terms of some signs, so again, louder sitting forward and on expiration. S3 heart sound is some things that have popped up. So just a little added sound here. And a wide pulse pressure is a big one. So comparing to aortic stenosis, this one has a wide pulse pressure. And then like a few other random signs that I can't remember if they've come up before, but Waterhammer pulse sometimes does, and you get that collapsing pulse. De Musset sign, so they kind of nod with the beat of the heart, and Quincke sign, so you can literally see. A few people are saying that they remember Maddie's performance to this, and yes, I'm not even going to try and upstage her. But yes, Quincke sign is you can literally see like the beating in their fingers as well. Very bizarre. Mitral stenosis is going to be a mid-diastolic murmur, rumbling murmur at the apex, and it's best heard in the left lateral, but you won't have radiation of your axilla to your axilla. So causes, so as I mentioned before, rheumatic heart disease is going to be a big one, but just don't forget that rheumatic heart disease can pretty much cause any murmur at any valve. Symptoms, again, it's on the right side, so the left side, sorry, so think of like your left-sided things, like your shortness of breath, all of that. Loud S1 at the apex, so it's going to be your apex, and an opening snap is also another key sign, as well as your mitral facies, so they can get quite red, flushed cheeks like this older lady here. In terms of our investigation findings, you can see bifid P waves, which is going to be our P mitrale, and a relatively straight left cardiac border. Don't worry about that, that doesn't come up. But yes, just know that this is kind of going to be your typical sound. So this is your P mitrale and pulmonale, just to clarify. So usually when you get the right and left atrium depolarizing, it's the left one just after your right one, and they kind of combine to produce your normal single P wave. If you have P mitrale and there's something wrong with your left side, you can see here, this is the normal left atrium, but if there's a problem with it, it'll happen a little bit later. So you'll end up with this little split between the right and left atrium, in the timing of their contraction. Whereas if you have P pulmonale and you have an issue with the right atrium, so this side here, that happens a little bit later, and it kind of gets added onto this, the left atrium side, and they'll kind of join to form an even bigger P wave then. So a good thing to know. So in terms of investigations, again, all of our typical bedside and bloods, but an echo is something that you absolutely have to do to kind of look at the morphology. Management's going to be very general because, you know, they're going to never going to ask you specifically how to manage one, I don't believe, but lifestyle, doing all your SNAP-W stuff, medical, treating their heart failure, as we have already discussed, and then surgical, there's a lot of different things you can talk about. But some good things to note is that the two different valves that they'll use, so a mechanical or bioprosthetic valve. Mechanical ones, they have a very long lifespan, hence they're better in younger people, but it does mean that you'll have to be on warfarin for your whole life. And warfarin is kind of, you know, usually we put people on DOACs now, but mechanical valves are one area where we still have to put people on warfarin. And we did have a question kind of relating to this last year, where you needed to know that a person with a mechanical valve was on warfarin, and that warfarin interacts with a lot of drugs. And then our bioprosthetic ones, they're shorter lifespan, so better for older people, and you only need to anticoagulate them for 3 months. So moving on to infective endocarditis. So this is going to be our fever and pneumoma, typical symptoms. If it's fever and pneumoma, it's infective endocarditis any day of the week. And so there's usually some sort of damage to your endocardium, which is going to be like your main picture, but we do have acute versus subacute. So for our acute IE, this is going to be our really highly virulent organisms like Staph aureus, whereas a subacute is going to be our less virulent organisms like strep viridans, mainly from like dentists and teeth and the mouth and all of that. So Staph aureus, and also less common Staph epidermidis, these are our acute ones, and they'll kill you quickly. So risk factors like IVDU, pacemakers, prosthetic valves. Whereas our less common ones, so strep viridans, is going to be from like dental procedures, or if you've already got a damaged native valve that makes you more susceptible to this less virulent form. And other ones that don't come up too often, but enterococcus, so this is from like gastro or genitourinary infections that have somehow got into the bloodstream and get into the heart. There's also atypicals. Just know that they're the Hayseck organisms, and this is like the main reason why we have such a broad range of cover when we treat it, and Candida or other fungal infections in immunosuppressed people. Yes, we won't go through this too much, but just know that you get vegetations on your valves, and it's fibrin, white blood cells, and the bacteria all kind of aggregating in one little vegetation, like we have all along the valves here and all along here. Yes, and this is just for your own learning. They don't really tend to question the different types of endocarditis too much, but just know infective endocarditis pretty much. So risk factors, lots of different ones, but if you have any damage to your valves, any artificial stuff in there like a prosthetic valve and IVDU are going to be your big ones. So you want to know the timeline, really nailing that down in your history. So knowing exactly when did it start, and if they've been unwell recently or any surgeries. Fever, rigors, night sweats, again, ask them all together. And then all like your typical cardio and resp type symptoms like dyspnea, chest pain, cough, blah, blah, blah. And then in terms of examination, from Jane is just a really good mnemonic to remember all of your different findings. So I guess key ones that come up like Roth spots, Osler nodes, murmur, definitely, Janeway lesions, and nail changes, definitely, that comes up often. And emboli is going to be your main complication. So investigations, we're going to definitely do some blood cultures. And one thing that they also like to question is specifically how many and when do you do them? So you need to get them from 3 different sites, 1 hour apart. Mainly because you're not going to go, get 3 cultures all from the same site, because if that site's contaminated, then all of your blood cultures are contaminated. And also doing an echo. So you need to do a transesophageal echo. If you do a transthoracic echo and you get what you think is a positive, what you think is a negative result, that does not rule out infective endocarditis. So you're going to go on and do a toe anyway. So just do a toe. And then our diagnostic criteria. So 2 positive blood cultures and radiological evidence with a toe, not a transthoracic echo, is going to be our major criteria. So if we have both of those, you've got a diagnosis. But if you only have 1 of those, you need at least 3 of your minor criteria. So do they have any risk factors, fever, vascular abnormalities, any immune disorders, blah, blah, blah. Don't need to know those off by heart, but just know that you'll have to have at least these 2 to make a diagnosis. And in terms of management, definitely like good oral hygiene, avoiding tattoos, talk about drug use as well, and antibiotics. So definitely know these 3, BFG, GBF, any way you'd like to remember it, but Fluclox, Benpen, and Gent, covering like all your gram positives and negatives. However, if you think that they've contracted it in hospital and that they're at a risk of MRSA or they have a prosthetic valve, then you should put them on vancomycin. So get rid of Benpen, put them on vanc. And anyone who's also a high risk, they need to have prophylaxis with amoxicillin. In the long term, you can also do valve replacement. I've said acute here, but that's if it's super severe, that's completely destroyed the valve, but something to consider long term as well. And our main complications here, so tamponade, in the kind of acute setting, and emboli as well. So we had an OSCE a little earlier in the year where we had a person with infective endocarditis who had a emboli that it was on the right side of the heart, so it had gone to the lung and have caused a PE. So I think it's very easy to think about like your left-sided emboli going to the brain or a limb or the gut and causing ischemia there, but just don't forget that you also get them on the right side as well. So PEs are very common. Cool. Also, if you want any questions, please let me know, or you want me to slow down or speed up, let me know. But rheumatic fever, heart disease, another great topic. So it's going to be our group A beta hemolytic strep, which is our strep pyogenes. So we have our acute rheumatic fever caused by strep pyogenes, which can go on to develop into rheumatic heart disease, which is our chronic complication. And it's mainly rheumatic heart disease because although it can affect skin, joints, brain, all of that, they usually resolve. Whereas if you attack the valves, that's obviously not going to resolve. Yes, so strep throat is our preceding infection that we'll have. And it's usually if there's no appropriate antibiotic treatment. Molecular mimicry is like our underlying path. So our antibodies are a bit stupid and they attack our heart as well, and skin and joints and all of that. Epi, so quite a low risk nowadays. However, our Aboriginal and Torres Strait Islander communities, as well as migrants, are at a greater risk due to just, I guess, lower ability to access antibiotics. And so still, unfortunately, quite a high incidence in these communities. In terms of risk factors, so just poorer education, age, they get more ERTs, and sick contacts. So definitely need to know these. So our Jones criteria, which is our major clinical features. So joints, which is a migratory polyarthropathy, not to be confused with just any arthropathy. So if I've got a sore elbow, that doesn't classify as a major criteria. I'd have to have a sore elbow that went to a sore wrist and sore knees and now sore ankles that is kind of changing. The O, or the heart, is our pancarditis, which can go on and lead to mitral stenosis as our big kind of like long-lasting effect. Nodules, so like down here, just little subcut nodules, not really too common, but I think it's pretty much just there to make the mnemonic work. Erythema marginatum, so here, very kind of clear, well-defined border with a central clearing. And Sydenham's chorea, so it's probably the one that will come on last. And they just, a chorea just means they get very erratic movements. And so it's like they're dancing, so yes. In terms of our minor criteria, CRP, arthropathy, as we said, fever, ESR, raised white cells, and a prolonged PR interval. So this seems a bit random, but have seen this in questions before. Don't forget. So we're going to want to test for the infection. So we can do a throat swab. You can do a rapid test, but again, if that's negative, doesn't rule it out. So you'll still probably have to do like a full culture and do your serology, blood cultures, all of that as well. And so we need, for diagnosis, we need both evidence of your infection from strep and 2 major criteria. Or 1 major, 2 minor, but it's usually the 2 major because it's going to be quite uncommon if they just have 1 major criteria. Antibiotics that we need to know to treat them is going to be our phenoxymethylpenicillin, which is our penicillin V, and that's oral. Or if they are not going to be compliant, you don't think they're going to be compliant, or for any reason they can't have, I can't remember, it's like a week or 2 weeks of this oral drug, then they have benzathine benzoylpenicillin, which is just an IM injection. and that's penicillin G, and it's just a one-off. In terms of pain management, typical things, NSAIDs, PPI, steroids if it's really bad, and you're going to need to continue the antibiotics for quite a while as prophylaxis. So we are finally at some questions, thank God. Send me answers for the first one. We'll just go through each one separately. Oh, my dog is going absolutely insane. Yes. You're all getting that right. So F, very good. So this is a flow murmur or just a very benign murmur that just isn't anything of any serious pathology. Key things for like your benign murmurs is that they're soft, systolic, and no heaves or thrills or anything like that. So if you ever have a time where you have heaves or thrills, that immediately says that something is wrong with the heart, with like the structure, or just something's wrong. And so it's immediately not benign. So that the fact there's none of that, it's soft, it's just going to be a flow murmur. What about question 2? Yes, you are all absolutely correct, 100% of you. So this one's aortic stenosis. I don't particularly like this question because they usually have a narrow pulse pressure, whereas this is not a narrow pulse pressure, but the picture mainly just fits. Aortic stenosis, he's an older person. He doesn't have any really severe symptoms yet, but ejection systolic murmur, left sternal edge, and it's up at the carotids. Carotid upstroke is slow. All big buzzwords for aortic stenosis. And how about 3? Yes, very good. You are all correct. Again, you are all very good at your murmurs. So this one is tricuspid regurg. So he's got swollen ankles, JVP's elevated, pansystolic murmur, pitching edema to his knees. So it seems like it's a right-sided issue mainly, and it's a pansystolic murmur. And so it's pretty much only going to be your tricuspid regurg as the cause of this. So a narrow pulse pressure is just between your systolic and diastolic. So if usually aortic stenosis has a narrow pulse pressure, so I guess if their blood pressure was like 120 over 110, I don't know if it's something that actually happens, but it's just the difference between the systolic and diastolic, whereas your wide pulse pressure, like usually in aortic regurg, they have a very big difference between the systolic and diastolic. I hope that makes sense. And this was just the key features of innocent murmurs, just to talk about before. So sensitive, they change with position. They're short, single, small, so it's just like a small area. Very soft, they don't sound very loud, and they're usually systolic. So yeah, diastolic murmurs are not good. And how about this question? Yes. Very good. There's the answer. So D, so this one, he's got severe chest pain, signs of aortic regurg, so a new murmur because there's no murmur noted before. And he's got intermittent pyrexia or fever. So to me, he's got a new murmur and a fever. This is infective endocarditis. Yes, very good. And this one. A few different answers on this one, but this one is I. Getting a few H's and A's. H and A. Yes. Yes, so the answer is I, so Trendelenpril, so Pril being our ACE inhibitors, and Sartan, so which a few people have said is our angiotensin receptor blocker. This is a bit of a tricky question, but I guess it's just always good to go with the ACE inhibitor first. And then if you have any issues with that, with side effects or anything, you usually go to your ARB. So it's a bit annoying because they're usually said to be, similar efficacy, but I guess always just go for your ACE inhibitor first, which is your Trendelenpril. And I think I put this question in and I added a few options, but I think it's really, really, really important to know your drugs and know your groups, because they can definitely have questions like this, and they'll put a few weird ones in as well. And it's also something really good to know just in terms of like being on clinical placement. So yes, and yes. I thought not putting perindopril was going to be a good option because it's the one that everyone knows. And so I tried to find like the less common drug for each group. So definitely know them. So we are nearing towards the end, getting onto arrhythmias now. I think arrhythmias are a hideously large topic that we could spend a long time on. So I will kind of breeze through these a little bit. But if you still do need info after this, or you're still confused, we do have a lot of resources on this. Maddie gave a really good lecture on ECGs and arrhythmias. So this is just mainly a summary of the key things. But again, if you have questions, just put them in the chat. So starting with the Brady arrhythmias, the main ones that we're going to be worried about are our AV blocks and our bundle branch blocks. And they're usually going to be very tired, fatigued. They might be fainting or wanting to faint, confused, shortness of breath because they've got a very low heart rate. So in terms of sinus bradycardia, this is less than 60. It can be normal. So athletes, or if you're on any sort of drugs that lower your heart rate, obviously you can have this. And there's some pathological causes, but let's not worry. Can do a lot of different investigations as well to look for causes. But in terms of management, our main thing is going to be, are they acutely unwell and do we need to like doctors ABCD them? And if it's really bad, we can give them atropine, so an anticholinergic drug to raise their heart rate. And we can also do external pacing as well. Yes. So our AV blocks is our main one to know. Main causes are going to be like our ischemic heart disease. So if you've had any kind of infarction throughout the conduction pathway, you're going to get a block. So our first degree ones is just a lengthening of your PR interval, but there's no drops yet. And then your second degree, so knowing between your Mobitz type 1 and Mobitz type 2. So Mobitz 1, which is our Wenke back block, is going to be where we get progressive elongation of your PR interval, and then it drops. And then Mobitz type 2 is just the PR not elongating, it's the same, and then one will just drop. And so that one's going to be worse because it's a bit more random. We don't know when it's going to drop, and often can go into a third degree, which is going to be complete dissociation. So random P waves and QRS complexes all throughout. And I guess to me, it seems easy when you just say it like that, but when you actually look at the ECGs, it can take a little while to actually realize what's going on. So really try and pinpoint where the P wave is and where the QRS complex is. So usually these people can be asymptomatic, especially like the first degree ones. But if they do become symptomatic, again, you know, if they're really unstable, atropine, permanent pacemaker will be needed. If they're not, just monitor them over long term. So in terms of our bundle branch blocks, so we've got 3 conduction pathways. I never knew this last year at all, but we've got our right and left bundle branch. And then in our left bundle branch, we have our anterior and posterior fascicles. And so you can get different blocks. So you can just have like just the right side or like the left side with one anterior or posterior fascicle, and it becomes very confusing and, to me, not something that you guys need to know or any of us need to know. But in terms of picking them in the ECGs, you need to know that your left bundle branch block is an AMI until proven otherwise. So if all of their previous ECGs are normal, but now they've got a new left bundle branch block, that's pretty much an AMI until you can prove otherwise. But the main thing you'll be looking for is that little W in your kind of like V1 to those kind of leads, and seeing the M in your like V5, V6. And then your right bundle branch block, you'll be seeing an M in your kind of anterior leads, like the V1, V2. And yes, that's pretty much all you need to know for them. And we'll have some ECGs on that, and that'll make it much more clearer. So atrial tachyarrhythmia is much more clinically relevant. So our AF, our 2 AFs, so atrial fibrillation and flutter, are the main ones we'll focus on. So sinus tachycardia is just over 100 beats per minute, lots of different causes. Our atrial flutter, so this is a type of SVT that arises outside of the SA node, so something within the atria is going wrong. And it's pretty much the same as atrial fibrillation in terms of its symptoms and how we manage it. But just know that the ECG is regularly irregular, as opposed to atrial fibrillation, which is irregularly irregular. So I guess what we're saying is that there's probably not a P wave before every QRS complex, so that is irregular, but it is regular in the timing of its irregularities. And I'll use an ECG to explain that further, because that's probably confusing. And then our paroxysmal SVTs. So this is where our AV-NRT and our AVRT come into it. And these absolutely confused the shit out of me last year. And so I just chose not to learn it pretty much. And so the main thing to know that I knew that helped me with the exam was that our AVRT is our Wolff-Parkinson-White syndrome. And this is where we're going to have a delta wave on ECG, which again, I have an ECG of this to show, but you pretty much just get like a slowed upstroke of your QRS complex. So I would look that up now if you want to know what that looks like. But it's just not a nice quick upstroke. It's just like a slowed upstroke, and then it goes up. You manage all of these, I guess, in the short term with like vagal maneuvers. So to try and increase like your parasympathetic tone. And that can be like doing the Valsalva. And I think there's like one where the dive reflex where you stick your head in water or something, but you can do those vagal maneuvers, but the main treatment is going to be IV adenosine. And one thing that I guess if sometimes comes up in questions, sometimes not, but with this drug, people feel like they're going to die on it. I don't know why, but they just do. I think it's because it literally stops their heart and just restarts it. But that's adenosine. Sounds amazing. And then you can go on to like cardiovert them and use catheter ablation in the long term to kind of remove the part that's like stuffing up in the atria. I will get back to your question, Nicole, at the end. So in terms of AF now, we'll spend a bit of time on this because this is super important. It was like an OSCE last year. It was in the questions. You need to know a lot about it. So for AF, 3 types: paroxysmal, persistent, and permanent. So kind of just worsening severity. Paroxysmal, it usually starts off like that. And I think, yes, this is a good diagram. So it starts off where, you know, the blue is normal, the orange is bad. So you get a few little random spikes of AF, but then it kind of progresses to symptomatic AF and it becomes more common, and then it becomes permanent. So you'll pretty much have it all the time with no real periods of sinus rhythm, and you're mainly symptomatic the whole time. And this is where people are in hospital, or they'll have strokes, or they'll die. This is a good little mnemonic, pirates, to remember kind of like both causes and precipitants of AF. So like PE, ischemic heart disease, rheumatic fever, blah, blah, blah. You can all read, but they're just key things to think of as well in terms of AF. Big ones, definitely thyroid disease. It comes up quite often. And yeah, I mean, they're all important, but thyroid disease, I guess specifically, is the one that jumps out to me as the one that's come up the most. History, it's usually going to be asymptomatic, as that picture showed, but as it gets worse, you'll get palps, fluttering, you'll get shitty cardiac output, so you can be quite dizzy, and you can get fatigue and dyspnea. So an irregular pulse is going to be our big key word to say. Hypotensive, tachycardic, blah, 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 so on. But here is where all the money is with AF. So we're going to do our ECG, of course. We're going to do our FB, coag profile, important, TFTs, very important, and also an echo, very important. You want to know if there's any valvular issue there, because the way that we manage valvular and non-valvular, valvular is different. So key principles, so knowing our 3 key principles of treatment in that: rate control, rhythm control, and stroke prevention are all things that need to be addressed. So here's just, I guess, a general breakdown of what we use. So for rate control, beta blockers or calcium channel blockers can be used. Mainly seen beta blockers though. Rhythm control, a few different drugs here, but it can either be electrical, so like your DC shock, or pharmacological, and then anticoagulation. So valvular, we'll use warfarin. Non-valvular, we'll use DOACs, so like rivaroxaban. So if they are presenting to you acutely, you need to know the kind of the 3 main timelines. So 1, if they're hemodynamically unstable, so a low blood pressure, super high heart rate, they look very unwell, that's just, you need to immediately shock them. Nothing else matters. You just need to shock them. If they are hemodynamically stable, but you are certain that they are presenting kind of less than 48 hours since the onset, you can pretty much just start with your initial rate or rhythm control. Usually will be rate control from what I've seen. But if you do rhythm control, you need to anticoagulate them first. Yes. So if there is any then question as to when they have presented, so if they think, oh, like it might be less than 48 hours, but I'm not too sure, they just get treated as if they are greater than 48 hours, because they're at a very high risk of forming a thrombus. And so you obviously don't want to shock someone with a thrombus there, because you'll just like flick it off, cause them to have a stroke. So in this case, if it's after 48 hours, you definitely need to get an echo done to see if you can see a thrombus. And so you'll probably initially start them on rate control, because there's really no harm in lowering their blood pressure, whereas there would be if you started to change the rhythm of their heart. And they'll usually need to be put on anticoagulation for 3 weeks before considering any rhythm control, where they will then start it. In terms of chronic management, so this is where we, again, do our SNAP-W, but we think of our CHADS-VA score, not VASC anymore. It's pretty much just removed like the sex component of it. But 0 is no anticoagulation, 1, consider it, but 2 or more is absolutely on anticoagulation. And you can just continue their rate and rhythm control as however it was already on, and manage any other complications, so their blood pressure, lipids, etc. So this is our CHADS-VASc score, which I'm pretty sure you all know. Someone's just asking, do we need to be able to calculate this score from memory? Oh, I would say yes, just to err on the safe side. I can't exactly remember how it came up in our OSCE last year, but it was a man who had a TIA and he had a few other things going on. And I think we needed to maybe calculate it. I can't really remember, but it would definitely be something good if you could. And you could say, oh, well, this man's had a TIA. He's 76 years old. He's got high blood pressure. And so immediately we know he's got more than 2 points and we definitely need to anticoagulate this man and treat him appropriately. So I think it would be very good to know it. Yes, as I mentioned before, valvular, you need to anticoagulate them with warfarin, non-valvular, a DOAC, and these are just some ADRs of the typical drugs. So good to know. In terms of our ventricular ones, so I'll kind of race through these, but VT, torsades, VF, and some ectopics are the key ones. Ventricular tachycardia, because we're now in ventricular issues, this is where we get really broad QRS complexes as opposed to atrial things which are narrow. And so VT will just have very broad monomorphic complexes. It'll just be very big up and down. Torsades, you get that twisting. So it's similar to VT, but it kind of moves up and down and it's not monomorphic anymore. VF is just complete irregular depolarization, and there's no form whatsoever. And that's an emergency. They pretty much all need shocks. And ventricular ectopics is just when you get like premature beats. So you'll just see like your normal QRS complexes and then like some random big one. And it's very predictable in that you get like 1 normal to 1 abnormal, or you'll have like 2 normal to 1 abnormal, and you can predict the rate of it. And these are just random ECG things for a few different causes. The main ones I would know are like the hypokalemia. They come up sometimes. So quickly going through cardiac arrest, because this has come up in a OSCE before. So someone's got a sudden loss of consciousness. I'll just give it to you. Obviously, we're going to do our doctor's ABCD. Key things to mention, like you want to have them on a hard, flat surface. So not like a big bouncy bed or anything that's not hard. And just mention C-spine precautions. But does anyone know the shockable versus non-shockable rhythms? Maybe. Yes, very good. So our shockable ones are VT and VF and torsades. And our non-shockable ones are asystole and PEA, which is pulseless electrical activity. So this will be a typical question where you will say that, oh, like the ambulance is like feeling no pulse at all for however many minutes, but the ECG is showing something that can look pretty normal. And so that is obviously like warning signs to you, because if you can't feel a pulse but the ECG is normal, you're like, well, what the hell's going on? That's PEA and it's not shockable. And just because of the sake of time, these are our reversible causes of cardiac arrest. So our like 5 H's and 5 T's, or 4 H's and 4 T's, but this has come up before. So just know these. And I'm going to zip past these. Hypertension is, it's hypertension. We all know it. It's mainly idiopathic, but in terms of investigations, you're going to look for a few different secondary causes. Going to need 2 readings for hypertension as well to have a diagnosis, not just 1 reading. And you're just going to look for a few like secondary causes if you're worried about it, like pheochromocytoma, hyperaldosteronism. Look at all your like endocrine stuff. And our treatment is just going to be obviously SNAP-W, lifestyle, all of that, and just an ACE or an ARB, and then you can either add a calcium channel blocker or a thiazide, and then you can just put them all 3 together. Is going to be like your 1, 2, 3 stepwise decision making. And then there's all these other weird random drugs which you can add for specific situations that you guys don't need to know. And obviously we're going to have all of these complications, which I'm sure you know. PVD can be arterial or venous, so think about both. But in terms of our history, it's going to be like our intermittent claudication, which is like, I think of it as angina of the legs. So when you walk or do anything that's painful. And the 6 Ps of PAD, definitely very important to know. It comes up quite a bit. So pallor, pain, paresthesia, paralysis, pulsus, and perishingly cold. And then in terms of venous, it's going to be, think of the blood all pooling down in their legs. So it's going to be quite swollen. They'll have varicose veins. It'll look very nasty. And just look for both signs of arterial and venous ulcers. So is it cold, pulse? Do they have any ulcers there, hair loss? And our Berger's test is something we would do, and looking at their ankle brachial index as well. So the blood pressure in like their arm compared to their leg, and it will be lower in their leg. And so this is just like the symptom kind of severity of PAD. So pretty much just the worse you are in terms of like your exercise or your intermittent claudication, like the worst category you fall into. And these are just the typical ulcers as well. So again, know these. I'm sorry, I'm running out of time, but just know these typical ulcer pictures as well. And this is our Berger's test, where you lift the leg, and what you'll see is that you'll just get, in a normal person, it'll stay nice and perfused. But if they have PAD, you'll lift the leg up and they will just go very pale, and then you'll drop it below the bed and they'll just have this massive like hyperemic response, and it'll go really, really red. And so that's a positive Berger's test. Whereas if it was normal, you lift it up and you'll put it back down and it will pretty much still be just as it was, normal. We'll do all of our typical investigations, but one to mention is like your ankle brachial index, as I said before. Do all your cardiovascular risk factor stuff, and you'll need to do some ultrasounds and CTs of the leg to specifically look at the arteries. Management is just, it's the usual management. Again, sorry, I'm going to speed through this, and this is the last one. So aortic aneurysms, what's important on this slide? So atherosclerosis, it's twice, that's how important it is. And hypertension absolutely is our biggest cause, as well as like connective tissue diseases, usually asymptomatic, but our typical buzzword is that when it's actually symptomatic, you get that kind of epigastric pain throughout your chest and it radiates to your back. Again, investigations, not really too important unless you start to become symptomatic from them. So like your FBE coags, a grip and hold or cross match if you're considering if they've ruptured and they need blood. And then you can do an ultrasound initially and move on to like CT angiography. For small ones, they're pretty asymptomatic. Just treat them for their like blood pressure and their lipid risk and all of that. But if they're large or symptomatic, consider surgery. My dog is going absolutely insane again. And then for a dissection, know between your type A and your type B. So your type A is anyone that involves the ascending aorta. So it can be the whole thing or just the ascending aorta. And then type B is anything other than your ascending aorta. So just the descending aorta. And then in terms of history, again, like a tearing or a really sudden onset ripping pain that radiates to the back. and they'll be losing blood. So they'll be tachycardic, hypotensive. They'll have a blood pressure difference. So between their arms or their legs, it'll be different. Can have a new murmur. And then our main thing to do is, like, because it's an emergency, we definitely need to get them blood. So an FBE, group and hold and cross match, TROPS and coags. And then we'll need to do a CT, chest, abdo, pelvis, to really clearly see where it is. And so we'll do our doctor's ABCD, our surgical workup, which is all of these things in brackets here. Know that really well. And for type A, I guess generally they need surgery. And then type B, it's conservative. So just manage their blood pressure. They're actually not that bad. Yes, and obviously their lifestyle stuff moving forward. So I am right at the end of my presentation now, and there are some questions at the end. I am aware that I've gone a little bit over time though. So yes, do we want to do these questions, or is there something that you guys are doing now? I don't know.
We have a bit of a break to 10:50. So I think it's fine if you go a bit over.
Okay, well, if you guys don't mind, I've got some questions. If you want to keep going for like 5 minutes. A few of you already sent your answers for these questions, which is good. This one is C, I showed it before. But yes, this one is chest pain right into his scapula. A cardiac murmur is noted, unequal pulses. Perfect example of a dissecting aneurysm. How about this one? I mainly put this one in just for fun. And I can see that a lot of people, I think a lot of you are changing your answers now. So yes, this one is I. I was a bitch for putting this one in, but I just wanted to really put the importance on this in terms of the causes of chest pain, and just to not ever forget that skin things and just other causes other than cardiovascular causes can cause chest pain. And this is extra tricky because it says that there's no obvious abnormalities upon inspection, whereas you would think there would be like a rash or something if it were shingles. But just know that most people actually present when they get that initial prodrome of kind of sensory changes. So if it's along the chest, they'll have that tingling or burning or some sort of pain, but they won't have any rash yet. And then you'll send them home, and then they'll come back in a few days and you'll see a clear rash and you're like, oh fuck, it's shingles. So don't forget about shingles. This one. I tried to put as many similar sounding drugs that start with A in this question, and I couldn't think of any others. But I've confused some of you. Oh, good thought, actually, from some people. Contentious. So this one is B. So as I mentioned before, in terms of our paroxysmal SVTs, the main thing to know is that you need to treat them with IV adenosine. So the drug that makes people feel like they're going to die. It's adenosine. Quite a few people have said A, which is a good thought, to be honest, because it's an anti-arrhythmic drug. But yes, it's just adenosine. I might actually skip through these, so you can look through these in your own time, just because I'd rather get to... yes, let's do this question. because those questions were a little bit older. They're good to go through, but this is more the style of question that they'll ask. Yes, very good. Everyone, it is F. So CCF is at a history of myocardial infarction, can't breathe when he sleeps, down, bibasal Krebs heard, low ejection fraction, all pointing to CCF. Again, I'll leave you with these. These are just murmurs. So go through those in your own time. And we'll just do a few quick ECGs. Here. Sorry for going so over time. So what is this? Some of you are funny. I was also confused when I saw this one for the first time and I thought, oh, I didn't look close enough. But this one is a left bundle branch block. So look very closely the QRS complexes. Firstly, they're very wide. So you know it's probably a ventricular issue. And you can see a little W there. William Morrow, a little W. And there's also a little M in V6. So points towards a left bundle branch block. A few people have said like first degree heart block, which could be it. And yes, it is a very teeny weeny W, and sometimes they can be very teeny. Sometimes they can be very large, but yes, that was a bit stiff. How about this one? I think this one is a little bit easier. Yes, yes, yes. Yes, very good. All of you have got that anterior STEMI. A few of you have said the lateral leads as well. Yeah, you could definitely think that, but I think mainly it's just like the anterior leads have the biggest rise, so mainly an issue there. Very good. How about this one? Very good, very good. This one is pericarditis, peri. Yes, it is. Don't forget, look in all of your leads, and there's pretty much ST elevation in almost all of them. So, very good. How about this one? Yes, 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 yes. Flutter absolutely is. This one doesn't look like your typical atrial flutter, but this is what I guess it means in terms of like it looking regularly irregular, and that you know there's this kind of repeating pattern of irregularity. Doesn't look like that typical sawtooth, I guess, but yes, it's atrial flutter. And this one is one that you should all have imprinted into your mind. Yes, AF. Very good. This is one that is a bit trickier. I may have spoken about it before. Yes, oh, you're all too good. Wolf, Parkinson, White. This is our slowed upstroke. So what I was talking about before, a little bit of a slower upstroke to the QRS. And up here, yes, yes, yes. And they're delta waves. Very good, everyone, for picking that up. This one. Yes, very good. Very, very good. VT And this one, these are all ones never, ever, ever to miss. Yes, Torsades. And this, VF, very good. Never forget those 3 ECGs again. They are something that are just unforgettable. You need to treat them. I think this is the last one as well. Yes. Yes. It is a secondary heart block type 2. So there's no PR interval elongation, and then you're just getting a random drop. So that's your type 2. Worry about this one. Yeah, and then if there was PR lengthening and then drop, that's your type 1. So these are just a few quick OSCE tips from me. So from what I have seen sometimes when we do OSCEs, I'm absolutely someone that used to do this, but my intro used to be so long. I used to be like, hi, I'm Alex, and like, how are you, and blah, 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 blah. And then you just talk about so much random stuff, and there's just like 50 seconds gone at the start of the OSCE. So cut down your intro. It's so easy to get down to like 15 seconds, probably less. Know your key complaints, chest pain, shortness of breath, blah, blah, blah. Have a really good list of differentials for all of them, and know how to really just bang out your questions for each of them. Definitely write your differentials and investigations on a bit of paper at the start. I don't know if you can now. I don't even know if we can, but I hope we can. Know your cardiovascular risk factors. I said right at the start, you need to know them. Yeah, forget SNAP-W, forget about being a doctor. It's a joke, but also not really. ECGs, there's going to be at least 3 or 4 questions in your EMQs about it, so you need to know them. Management, don't stress too much about management. I think that's what I got caught up a bit with last year, knowing specific management for like every condition in the whole matrix, but it just does not come up. So if you're feeling like you're getting really bogged down by it, just honestly forget it and focus on your key things like acute coronary syndrome, CCF, and like asthma, COPD, those key conditions. And know how to deal with different types of OSCEs, like your counselling stations. So like your IPC BRAD, how to break bad news, and doing explanations, or like how to start someone on a new drug, or giving someone a diagnosis for something. These are just some mnemonics that you can use. So I guess my parting message is that you'll all be fine. Don't stress. This year's been really shit. It's going to be fine. Some of you may get shit scores. Some of you may get really good scores. But at the end of the day, you'll all be doctors, and I'm sure you'll all be fine. No one cares about the score that you get. So just do the best you can, and you'll all be in 4C next year, and it will be a normal year, and it'll all be fine. So I wish you all the best of luck for your exams, and yes, we'll all see you next year.
Perfect. Thank you so much, Alex. As I was saying to Maddie yesterday, you and the entire team at Westbots have been an absolute lifesaver. Probably wouldn't know what to do without kind of your weekly sessions and notes. So thank you for that.
No worries at all.
Thank you for the presentation. We have our next one. We were scheduled for 10:50, but we might push that back slightly by 5 or so minutes. And we also have a quick message from our sponsors, who I think should be here today. And they would just be having a bit of a chat about MIGA, what they do. So I think they can do that now, if that's fine. And we shall probably come back at about 10:55 or 11, and then we can start with RESP then.